Hello everyone, and welcome to this webinar tackling COVID-19 Dutch academics in the UK. I hope you're all having a really good afternoon. It's great to have you all here, and welcome back for the people that have joined Dutch Academic Network in the UK event before, and hello to people that are joining for the first time. I'm Pauline, and I'm a filmmaker and journalist based in London. Before we start, I have a few general announcements to make. Please be aware that you are muted. In case you have a question for one of the speakers, please type it in the Q&A section, and we're hoping to get an answer for you from as many of you as possible. You can use the chat for general issues and other questions, but the Q&A sections for questions. So yeah, thank you for tuning in. We'll be talking about such an interesting and pressing topic today. We've all been experiencing the effects of COVID-19 in the past 2 months, but the speakers that are joining us today have an even special or more in-depth experience of COVID-19. This webinar is organized by the Dutch Academic Network in the UK, DANinUK, in collaboration with the Dutch Embassy in the UK. And they wanted to highlight the work of Dutch academics in the UK during this pandemic. The 3 academics that we'll be hearing from today all work in important areas linked to COVID-19. And yeah, we'll hope that you'll all be leaving intrigued and inspired, of course. So the 3 speakers that will be joining today are Dr. Jeroen Nieuwland, who developed a fast COVID-19 test. Then we'll continue to Professor Marcel Levy, who is the CEO of University College London Hospitals and has been in charge of organizing the medical care for some of the hospitals. And then to Vandermark, who has been studying the impact of the virus on global health. In addition to that, we've also created a series of films where we interview the 3 speakers, and you'll be able to watch these videos on YouTube. Before we start, we actually want to know a bit more about you. So there's a little poll that we're going to pop up right now, which is, well, where do you live? I'm really curious to find out a bit more. So please go ahead. I'll give you another 10 seconds to answer. I think that's about it. I'm curious to see the results. There we go. Okay. Well, that's a good combination. Most of you in the UK, quite a few in the Netherlands as well, and elsewhere. Fun. Well, welcome all of you. Then I'm going to hand over to Brechtje Zwagheuver, who is the Deputy Ambassador to the Dutch Embassy in the UK.
Yes, and thank you for your introduction, Pauline, to this event. And also on behalf of me and my colleagues at the Embassy, a warm welcome to everybody to this seminar. A seminar which I've been looking forward to this whole week, having watched the interviews with today's speakers that we posted on social media. And there were beautiful productions, I think, made by you, Pauline, today. So congratulations on that. And there are a number of reasons why I'm particularly excited about this event that we're running today with DANinUK. Firstly, it's great to see that the Dutch Academic Network in the UK is thriving. The network was initiated by the Dutch Embassy, but it is now an independent organization with its own board. And it's less than a year old, and it already has over 100 members, so that is very impressive. And networks like these play an important role in connecting people from the Netherlands with people in the UK, our North Sea neighbors. A second reason why I'm excited about today's event is the collaboration between the Dutch Academic Network and ourselves as Dutch Embassy in co-organizing this together. And that cooperation has been tremendous. So a big thank you from all of us at the Embassy for the board members of DANinUK for doing this with us. It's the first online event that we do together, and I'm sure that many more will follow. And finally, I believe today's event perfectly illustrates how valuable international collaborations are. We will hear stories, as Pauline indicated just now, from 3 Dutch nationals who are all living in the UK, working at renowned British institutions. Importantly, their work is making incredibly valuable contributions towards efforts to stop the global pandemic that is massively impacting all our lives. And this pandemic can only be tackled if we work together internationally. And it makes me really proud to know that lots of Dutch researchers here in the UK are doing their bit in keeping us all safe and healthy. I wish you all a very insightful afternoon. Thank you very much. Back to you, Pauline.
Thank you very much, Brechtje. Just a quick summary for people who joined in a little later. We're here to discuss the COVID-19 response and the work of Dutch academics in the UK and the work that they've done to tackle this virus. In case you have any questions, type them in the Q&A section and use the chat for technical issues or other questions. We're now moving on to the next speaker, Martijn Zwijnenburg, who is the president of the Dutch Academic Network in the UK.
Okay, thank you, Pauline and Brechtje, and welcome you all. I'd like to welcome you all on behalf of the Dutch Academic Network. I'm now going to try to show you some slides, which hopefully is going to work. Yeah, so we are the, as Brechtje has already introduced us, we're the Dutch Academic Network in the UK. We are a social and professional network of Dutch academics working in the UK, both at universities and at research institutions. And we are basically, and we have two aims. Our aim is both to establish a strong cooperation between the Netherlands and the UK in the fields of higher education and academic research, but as well as to promote strong social and professional interactions between Dutch researchers working in the UK. Besides today's webinar, we have organized and are organizing a series of events and other things. So as we had a launch event in January, which now feels like years ago, but it's only like 7 months ago, where we launched our network in the presence of various stakeholders, including the Dutch Minister for Education, Culture and Science. Only last June, we basically, together with the Wellcome Trust and a number of similar organizations in the UK, similar to us in the sense that sort of like for Polish, Spanish and Portuguese researchers, we launched a petition which sort of aims for a close integration between UK and European research after Brexit. And this fall we'll be launching a mentoring scheme which aims at supporting Dutch academics arriving in the UK, sort of showing the ropes, how does the UK system work, and similarly for Dutch researchers who are currently working in the UK, returning to the Netherlands and sort of helping them find their feet back home. If you're interested in what we do, please follow us on our social media channels, including our website. And if you have any questions, please don't hesitate to drop us an email on the email address on the slide. So here I would like to finish, and I hope you all enjoy this, what I assume will be a very, very interesting webinar this afternoon.
Thank you very much for that, Martijn. We're going straight into our first speaker. So Jeroen Nieuwland studied biology and did his PhD in plant cell biology in Nijmegen. After successfully applying for a Marie Curie postdoctoral fellowship at the Institute of Biotechnology at the University of Cambridge, he moved to the UK. He's now a senior lecturer at the University of South Wales. And in addition to lecturing molecular biology and genetics, he also developed a rapid and affordable COVID-19 test over the past months. How this came about, he will tell you later, because before we go to Jeroen, we have a quick poll for you, the audience. And the question is, I am certain that there will be a vaccine available by the end of the year. Do you agree or disagree? I'll give you a little bit of time to answer. 10 more seconds. And there we go. Yeah, I'm curious to see what the results are. Ah, okay. So it's interesting to see that 70% or 71% is not too certain that there will be a vaccine. But hopefully there will be a rapid test, and we'll hear about that now from Jeroen. So yes, please, Jeroen.
Hello, thank you, Pauline, for the introduction. I was going to introduce myself, but I guess you've done a great job. But I think if I tell a little bit more about myself, hopefully, you understand where I'm coming from with my test as well. So I was born in the Almelo region, in east of Holland, but I think I turned out all right in the end. Anyway, so like Pauline said, I moved to Cambridge, then Cardiff, and now I'm working in University of South Wales. And I guess after my PhD in Holland, I progressed my scientific career through different roles. I think so. I've done fundamental research in Cambridge and Cardiff, but about 5 years ago, when I took up a senior lectureship in the University of South Wales, I moved away from, like, say, the pure plant genetic research, and I started to do much more applied research, which I actually really enjoyed. I mean, I must say, after 8 years of fundamental research as a postdoc, I was sitting in a room in a dark room, looking at an asymmetric cell division in a plant root for 6 hours, and at that point, I didn't really feel like a biologist anymore, and I wanted to broaden out again, and that's why I took up teaching, which I really enjoy. And I try to work on more, let's say, societal challenges rather than pure research. And don't get me wrong, I've worked in pure research, and I definitely know it's very it's very important. But I think the UK is interesting in a way that applied science is a little bit. I guess it might be a little bit underfunded, and it's too much focus on pure research. But that could be, people might not like that. But that's what I think anyway. In any case, how did I start working on a COVID-19 test? Well, I started about 3 years ago, and there's been a national call from the Longitude Prize, and this is a prize basically based on a very ancient marine problem. Is basically the position of a ship to find out where it is on the ocean. You need to know what the time is, and those centuries ago, a competition was written out to make, to basically to find a solution for finding time. And in any case, let's say the modern watch was invented, and the Longitude Prize was given to the inventor. So the UK government, about 5 years ago, they asked the UK general public, what kind of massive societal challenge should we work on as a country? And by vote, antimicrobial resistance was voted. There was a 7 to 8 million prize money is involved with this, which made me focus actually, because I thought, I would like a bit of that. Of course, unfortunately, it's not for me to buy a boat or something, but it's actually to work on, to put it in clinical trials, for example. And the prize was asking for a detection test of a bacterial infection that would be cheaper than a course of antibiotics and faster than 30 minutes, which is a huge challenge. And actually, the over 200 teams in the world are working on this, and they've extended the prize because it is actually very difficult. It's not so difficult to detect an infection, but it's difficult to do it very cheaply and of course specifically and in a robust way. So we've been working on that, and we received funding from Nesta to do this. And our approach was to use loop-mediated isothermal amplification, which is a is a mouthful, and I'm sure not all of you are molecular geneticists, but basically it works on in a way to amplify a genetic code specifically. I don't know how your biology is, but all life on Earth shares the same language, which is genetic code, so G, A, T, and C. And between humans, we are very, very similar, but we're still very similar compared to, if you compare us to the primates, for example. But what you can find are specific genetic codes for specific organisms. So, for example, we were trying to detect E. coli in urinary tract infection specifically. So we looked for a specific genetic code, and we were trying to amplify that specifically. And you do that by putting a little bit of DNA that actually matches the specific code for E. coli in an enzymatic reaction. And the beauty of the LAMP reaction is compared to, let's say, a classic polymerase chain reaction, is that you don't have to change the temperature. For a PCR, and this is actually a classic and the most used test in a COVID-19 test, you have to use a machine that can cycle the temperature very precisely up and down, which is not a problem if you work in a lab and you've got a lot of money, but it makes the machines quite expensive. So in any case, we were using LAMP, which will use one temperature, and it basically zips open DNA and it will amplify it specifically. So that's important. So we're working on this, and we found a way to specifically amplify E. coli within 20-30 minutes. And I won't get technical. There's a lot of stuff that we still need to work on. But in any case, in January, February, we thought, we could use this technology in trying to detect COVID-19. Because COVID-19 is, well, it has a genetic code, so the same principle will work. So we looked for specific bits of codes that will only attach to the COVID-19 virus, and we used it in a LAMP assay, and it worked quite quickly. So that's only actually a tube that you can use in a lab. And of course, the challenge now is to bring it out to the community, and we're working at the moment very hard to do this. And in fact, we're working with a fellow Dutchman, Jeroen, who is the CEO of Health Enterprise East, and helping us to basically translate our work from our lab into a commercially and regulatory viable option. So the image you're looking at now is a 3D rendering of a machine that we've produced together with our electronic engineers, and it's very simple. It keeps the tube temperature at a certain stable temperature, and it will look for the amplification, so the production of DNA, which is actually fluorescent light. So what the user needs to do is basically put the tubes with the sample, close the lid, press start, and a green light will tell you there is no infection, and a red light, it will tell you there is an infection of that sample. And we can run 6 samples in each go, and you get the results. Well, actually, if somebody is severely infected, we see the results in 10 minutes, but we will wait until 30 minutes because lower rate infections could be detected later. So can I have the next slide, Pauline? The other advantage that what we're trying to do is that, so we don't need a lab. So it's going straight from a swab in a nostril, dip in the tube, close the lid of the tube, and place it into the machine. So that's where we are now. And actually, in 2 weeks, we get the first prototype of that machine. So we're very excited, and we can test our a method and basically combination of the machine. Can I have the next slide, please? One of the challenges that we have to go through is regulation. Of course, a test like this needs to be very safe. And so we need to go through CE marking and to make sure that the users can actually trust the result. I strongly believe in the molecular reaction underlying, which is actually being published and is used in other countries. But what we're really trying to do is make this machine very affordable, and hopefully we can use this in other countries as well, in low and middle income countries. there are a lot of challenges. People will talk about this. This last couple of months has been the most interesting time, professionally for me. There's an incredibly fast innovation development. Everything was go, go, go. But it's very difficult to keep everything together. So Job is going to help me with the project management. Of course, we have to think about safety while we're doing this viral work. And I'm a scientist. I'm not, I'm not a businessman, but because of the regulation, it needs to be a company that's selling the tests. So I'm learning this at the same time. So very interesting work, and hopefully we'll get something that is available in September, October. And it's hopefully we don't need it, but there's a pretty good chance for a second wave, and COVID-19 won't be over in the rest of the world for sure. Okay, so I think I will leave it here. My 10 minutes are up, and I will hear if you've got any questions later. Thank you.
Thank you very much for that, Jeroen. And as we said before, there will be a Q&A at the end. If you have any questions for any of the speakers, please type them in the Q&A box, and we'll try to get as many answered as possible. Also, for the people that I see some of people have joined now, thank you very much for joining this webinar on Dutch academics in the UK that have been tackling COVID-19. We have 2 more interesting speakers for you to come, and then we'll go into the Q&A. So stick around. The next one up is Professor Marcel Levy. He's the Chief Executive of the University College London Hospitals and Professor of Medicine at UCL. He's a consultant in acute medicine and hematology at UCLH. Previously, he was the Dean of the Faculty of Medicine of the University of Amsterdam, and also Chief Executive of the Academic Medical Center in Amsterdam. The past few months have been extremely intense, and I'm sure we'll hear more about that soon, because he was in charge of the COVID response for some of the hospitals in London. But before we move to Marcel, here's another poll for you. The poll is, I'm confident we won't be needing extra ICU beds this winter. What do you think? I'm gonna give you another 10 seconds. Five more seconds. A few more extra people answer. And that's it. Okay, a similar percentage as the previous poll. Well, I'm 73% of you thinks we might be needing extra ICU beds this winter. So I'm curious to hear what Marcel thinks of that. So Marcel, over to you, please. Oh, 1 second. Marcel, you're muted at the moment.
Yes, sorry, classic mistake. Thank you very much, Pauline, and it's a pleasure talking to you and speaking in this symposium. I'll try to share my screen. There we are, I think. Brilliant. I hope you can see it. Yeah, it's a big pleasure. I actually have 3 roles in the UK. I'm Chief Executive of University College London Hospitals, which is a combination of a group of academic hospitals affiliated with UCL, which is a university in London, where I'm Professor of Medicine, so I do a little bit of research there. And I'm also a consultant, which is kind of a medical specialist title in the UK for acute medicine and hematology. And actually during the COVID epidemic, I had to fulfill the 3 roles, which was indeed quite intense, to be honest. It's actually, if you look back, it's only 6 months ago, I think, that we've never heard of coronavirus, or at least the type of coronavirus that's causing COVID-19. And it's a tiny virus. It's only 100 nanometer, which is really small. It has 15 genes, which is also not a lot. but it has turned the world upside down. And certainly that was also the case in London. And you probably remember from January of this year, this interesting picture when they were building a new hospital in China. And we were all looking at that and we thought, wow, what's going on there? It's actually quite impressive, but it's far away. And we don't know whether this is ever going to touch us. But then very soon after that, in February, the virus came to Italy and to Spain. And we saw these pictures of intensive cares being overrun by very sick patients and many patients attending to hospitals. But interestingly, at that time, the UK was ready, relaxed, and thought, well, you know, there's a lot of stuff going on, but you know, it's still far away, Italy and Spain, and many people were still believing that this would not ever reach the United Kingdom. I've been quite privileged to work in Italy many years ago with Giancarlo Agnelli, he's the lead of the University of Perugia in medicine. And I was working there as a junior doctor, and one of my colleagues was Flora Pavandi, and she is now the lead of internal medicine in Milan. And Anna Falenga, incidentally, also worked there, and she's now the head of the University of Bergamo. And they were actually, I was emailing with them, and they said, well, this is coming your way, it's a very contagious virus, you need to prepare yourself, because if you don't, your hospitals will be completely overwhelmed by this. And at exactly the same time in London, I had 3 very young people working on my ITU, which are and you showed their faces here. And they came to me, they have a big interest in emergency preparedness. And they say, we need to prepare now before it's too late. But we didn't get a lot of support from the NHS or the government because they were still thinking that this was a non-UK problem. Until the first patients, of course, also hit the UK. And then there was a lot of panic and a lot of stuff was happening. And well, at a certain point in time, even the UK decided that we should go into lockdown because there were so many patients coming to hospitals with a doubling factor of every 2 or 3 days that it was quite clear that this was not going away. In the meantime, fortunately, we took a lot of time to start our preparations because if you want to prepare yourselves for a pandemic, a lot of change need to be introduced in the hospital. And this is just, I'm not going into detail here, but this is just a list of things we needed to do. We had calculated that we needed to quadruple our intensive care capacity, that we needed to prepare all our hospital wards and the emergency departments for all this. I'm leading about 7 hospitals in North Central London, but it became very clear that we needed to coordinate the response. So I was being asked to coordinate all hospitals in North Central and also Central London, which is about 17 different hospitals. So it was quite a busy period with a lot of telephone conferences, later on Zoom and all that other terrible stuff came online. But as you can imagine, quite a hectic time throughout March. And it was just more than just, you know, having more intensive care beds or emergency departments. It means you have to change all the hospitals. You have to move other activities to other sites that may not be used for patients with the virus. And of course, it's not only beds, you need staffing. And we can quadruple intensive care capacity, but then you also need to quadruple your intensive care nurses. And we simply don't have them. So we started a program that a lot of our medical and nursing staff could be very actively educated and very rapidly educated to work on an ITU, which was a lot of work for us, but also extremely stressful for these people because they thought they were going to do work they were really not very familiar with, despite the extra education we were giving them. Of course, there were also patients with a lot of urgent conditions that had nothing to do with COVID, like cancer or heart attacks or stroke. So we needed to secure sites for these patients so that we could also deliver care to them. And also, nowadays, you can't do anything in a hospital without connections to an electronic health record system. And if you change all the beds and change all the wards and change all the different things in the emergency department, you also need to make all these corresponding changes in your electronic health record system, because if not, it simply is not going to work. Virology testing was not online. We've just heard what a fantastic development there have been, but there was actually nothing or very limited at that point in time. And how can you combat a pandemic if you cannot even test the patients with an appropriate test for whether they have the disease or not. And certainly a lot of patients had to work from home, and we needed a technology to enable that, divert telephone lines, make it possible for them to access IT. May sound very logical for you, but those of you who know the NHS know that in IT terms, we're about 25 years behind every other country in Europe. So this was quite a big leap to take. And then of course there was a PPE, personal protective equipment issues. It was simply not available. There were no masks, no gowns. The national supply chain really didn't work very well. So we had to do it ourselves and had to find these materials everywhere in the UK and in the world to get them. Because how can you explain to your staff that they have to treat very ill patients with a very dangerous disease if they cannot protect themselves? That's almost impossible. And there was a lot of anxiety and concerns in staff as well. What's going to happen to me? What's going to happen with my family? My parents are living in my household. Can I safely go home after I've worked in the hospital, and so forth and so on? So we had a lot of time to spend with information meetings. And usually when you do an information meeting, 50 to 100 people show up. But now we had suddenly information meetings where thousands of people showed up because they were really concerned about what was going to happen. So just to give you a little bit of a flavor of the size of things, London is a big city and Central and North London are very heavily populated. So we were able to, in a matter of 2 or 3 weeks, to increase our intensive care beds from 250 to 1,000. We also created 1,200 hospital beds specifically dedicated for COVID-19 with isolation facilities and everything we needed. And importantly, we created 4 separate hospitals for the care of non-COVID-19 urgent patients. 1 for cardiology patients, 1 for cancer patients, 1 for stroke patients, and 1 for pediatric patients. We doubled the capacity of 7 emergency departments. We had to redeploy and train 10,000 staff, and we had certainly 40,000 staff working from home and created the facilities for them. Then, and I'll come back to testing at the end of my presentation, we had to, of course, increase our testing capability. We had to procure PPE, and just to give you a flavor, we actually procured 800,000 pieces of PPE. So this is masks, gowns, gloves, and everything, and that's per day. So you can also imagine there is an issue with where do you store all that stuff and where do you keep it safe? Because there was a point in time that it was actually quite vulnerable for theft. And then there were thousands of other issues like transportation, staff housing, parking, food. Well, you may think it's trivial, but actually it is not for staff working in a hospital environment. So I think one of the better decisions we probably took was when we were thinking who was going to do all this, that there was actually only one solution, because this was everything was connected. It was very complex. It was a huge amount of work. And in the UK, usually you look at other people if there is a complex problem, and in particular to managers. So the question we ask ourselves, who is actually going to do all this? Who is going to help us with all this? And we very quickly came to the decision that at least nobody who you see on this slide is going to do this. So the solution was, let's do it ourselves, but in particular, let our professionals take the lead. So the nurses and the doctors and the other professionals in the hospital, we gave them endless permission. They didn't have to ask for money. They didn't have to ask for approval of the board. They didn't have to fill in a risk register. We just said, do what you need to do. And I think that was a very wise decision, because that's exactly what the professionals did. And of course, we have lots of managers in the UK. There are plenty of managers in all kinds of roles, but they certainly had a much more supportive role instead of a managerial role. And actually it fitted them very well. It was very result oriented. And the only thing I did from the top down was a total ban on PowerPoints, because that's a total waste of time if you really need to get something done. And the other thing was that we decided that we could only do this if we would work as one team. So the doctors, the nurses, the allied health professionals, the physios, the admin people, the security people, the porters, the caterers, the cleaners, all belonged to one team. And that was the way we organized ourselves, and people were really happy with that. And lastly, I think it was important that we are an academic group of academic hospitals. So we thought, well, let's try to take benefit of our academic status and our connections and ties with the university. And that was personally for me very important. My hobby, to say so, in science is blood coagulation and thrombosis. And suddenly it turned out that this COVID-19 disease had a lot of serious thrombotic complications, clots in the lungs, clots in the heart, clots everywhere in the body. So there was suddenly also a research question, which was what is actually causing this hypercoagulability of patients in the intensive care and in the wards. So I was also very busy having loads of patients, doing research in them, and we could identify a couple of pathways which were really important. And then suddenly you have to write lots of papers, or you're being asked writing lots of papers on top of all the organizational work and on top of the clinical work I was also doing in the hospital. But you know, if you're busy, you can do so much more than what you normally do. And the other interesting thing was all those papers were accepted within 1 or 2 days, which is totally uncommon. But it's actually, according to me, as it always should be. So it was a very dynamic, also from a scientific point of view, very dynamic view. But of course, that was not the only science that was taking place. This is just another example from UCL. Here you see Mervyn Singer. He's one of my colleagues in intensive care. But he's also a professor at UCL, and he worked with the biomedical engineering department, and interestingly with the engineers from Mercedes Formula One. And they designed from scratch a new non-invasive ventilation machine, because as you may remember, there were not enough ventilators in ITU for all the patients that were coming our way. But they invented it within a week. They tested it in another week. They got approval in the 3rd week, and it was actually mass produced in the 4th week. And they have now produced, I've heard, in the order of magnitude of 100,000 of these devices, not only for the UK, but for everywhere in the world. It's freely, the plans, the blueprints are freely available. Nobody has to pay for it. It's quite easy to make. And I think this is one of the most fantastic examples where science can very directly affect outcomes in medicine. And another example has to do with testing as well. Like Jeroen, we didn't have any tests, so we worked with the Crick Institute here in London, which is usually a very highbrow molecular biology institute. But the researchers there, and part of them are also clinicians in our hospitals, took it upon them to develop tests with chemicals that were not scarce, so that were much more freely available throughout the world. And very quickly they developed an automated test which can now run more than 10,000 samples every day, not only for our hospitals, but for a major part of London. And that helped us enormously to facilitate, you know, the flow of patients in the hospital, because rapid diagnosis is really crucial to identify patients, but also now in the phase where we are now, to identify little clusters of infection. So it has been an intense period. I think it has been very intense for healthcare. We are now entering a new phase where there's not so much COVID anymore in London, but we try to get everything back online with the knowledge that we've gained about coronavirus infections. We've learned a lot about vulnerability of patients. We've learned a lot about how we need to organize ourselves for the future, how we actually can better work together as healthcare institutions and healthcare and academia. So I think COVID is in a way a kind of a magnifying glass that learned us a lot that was already there, but made it much more clear. So it has not been an entirely negative experience. Instead, I think it has been very positive, and we indeed have learned a lot of how COVID can be managed in the future. And I hope we will find a few minutes in the discussion to talk about vaccination, because the UK is the epicenter of vaccination research, and I think people are much too pessimistic about vaccination, and please be assured we will have it before the end of the year. Thank you very much for your attention.
Thank you very much for that, Marcel, and thank you for addressing the vaccination as well. We'll come back to that in the Q&A as well. Thanks everyone still who's around. Great to have you all here. And we have one more speaker left for you, Nina Vandermark. And after that, we'll go into the Q&A. There's lots of questions coming in already, and we'll try and do our best to answer as many as possible. So yeah, then Nina Vandermark works on universal health coverage and health system reforms. Her research is primarily focused on the political economy of universal health coverage and accelerating health system reforms in low and middle income countries. In the past months, she's been focusing on the impact of COVID-19 on these countries as well. And we look forward to hearing more from her. But first, a poll for you guys. So the poll is, I believe Africa is better prepared for a pandemic than Europe. And I'll give you another 10 seconds. Three. And yes, let's see what people think. And again, a similar division as the first two polls, funnily enough. So a majority of people, 73%, thinks that Africa is not better prepared for a pandemic than Europe. And I'm curious to hear what Nina thinks of that. And yeah, so over to you, Nina.
Hi, everyone. So yeah, thank you so much for that introduction, Pauline, and also thank you to the other speakers for those excellent presentations. So just to tell you a little bit about me and what I do. So I work as a research analyst for the Center for Universal Health at Chatham House. And so we were previously the Center on Global Health Security, but under leadership of Rob Yates, we're sort of now focusing on health security, still universal health coverage, and with that health systems, and also the social determinants of health, which basically means the conditions in which people live, play, work, etc., that have impact on health outcomes for people. So let me start by saying that it's perhaps very ambitious to talk about the responses on against sort of COVID-19 and the responses in a whole continent, let's say. So we really can't say that there is one, you know, COVID-19 trajectory in either the African continent or South Asia. And just so you know, that's sort of where we tend to focus our projects. So I'll be speaking a little bit about both. And so even some of the sort of the early hypotheses on impact in South Asia, and for example, also in Africa, for example, about having a younger population structure, perhaps that higher temperatures would sort of help with mitigating the impact of COVID-19. These are all still unfounded. So I think it was very interesting, for example, to hear John Nkengasong, who is the director of the Africa CDC, say, you know, we really, you know, you need to know your epidemic, or in this case, your pandemic, to be able to respond to it properly. So just a little bit on the response in Africa. After, I'll speak a little bit about South Asia, some of the impacts and sort of some exemplar countries. And I'll try to keep it to 10 minutes, but do let me know when I'm starting to run over. So a little bit on the African continent. I will say that I think in terms of this pandemic, the continent has been better prepared than ever before. Why? Because there are sort of existing infrastructures from the lessons from Ebola and HIV/AIDS. There's more sort of testing and surveillance capacity. In the beginning of the pandemic, the Africa CDC managed to ramp up testing capacity from pretty much 2 countries to 44 countries. There is a joint continental strategy. There's a task force, and you know, there's been incredible sort of resilience and some really sort of effective strategies used, especially in terms of community engagement, which is also sort of a legacy infrastructure of Ebola, who have an extremely important role in debunking myths, giving information to communities, and working really in sort of the front line of the response. Then, of course, there are also constraints, especially in terms of, health infrastructure. I think health systems in both Africa and South Asia are dealing with, let's say, a trifecta of having a developing economy, having a fragile public health system, and dealing with this pandemic as well as underlying vulnerabilities. So, for example, if we look at Afghanistan, which is a conflict-affected country, we see that, with 11 testing labs and in an absence of sort of a national death register, really the amount of cases that are being reported are heavily underreported, let's say. So this ties back in again in terms of the importance of information and the importance of reliable data in terms of responding to a pandemic. And then I'd say also in terms of, the high levels of population living in informal settlements. So, large numbers, for example, in South Africa, around 3 million, and in Bangladesh as well, in Dhaka, similar figures there. And when people do sort of live in informal settlements, and when there's high levels of the population working in the informal economy, policies like lockdowns can have really adverse effects on their access to food and essential services as well. So I think, it's been really difficult for health systems that are already overwhelmed to deal with the additional sort of surge of cases with this pandemic. And then I'd also say that there's something to say for sort of the pre-existing capacities of the health system. So in terms of longer term investments in health, really sort of financing of the primary healthcare system. When we look at South Asia, for example, which is a region with extremely wide disparities, but nonetheless, most countries in South Asia have been spending around 1% of their GDP on their health system for the past 10 years, if not more. And the difficulty with that is that with underinvestment and a lack of public health, a lack of an adequate public health system, people tend to move towards private providers, which tend to be quite unregulated. So, for example, in India and in Bangladesh, we've got, out-of-pocket expenditure, meaning sort of what people pay directly for health services, of up to 70%. So when people have no trust in the public health system, they tend to present late with symptoms, they tend to not go to facilities, and that is sort of a further challenge as well. And I think also in terms of social protection services, in the absence of these types of strategies, again, with lockdown policies, when, it's very hard to maintain adherence to these policies when people have to choose between getting sort of their wage for the day or going hungry. So I think this pandemic will have widespread economic impacts. I mean, we've seen data from the IMF on sort of, let's say, a 3.2 shrink in the African economy, and up to sort of negative growth of 1.8 to sort of 2.8% in South Asia as well, which was earlier predicted to have about 6.3% growth in 2020. I think we need to talk about debt as well, debt servicing, which is really high in these countries. So there needs to be some international cooperation in terms of talking about these issues, and debt forgiveness as well. Food security, people who are already affected by sort of an insecure food situation will likely be in a worse place during and sort of in the aftermath of the pandemic. Health impacts, as well as sort of peace and security in conflict affected states. But I think it's also really important to look at the exemplars, to look at the outliers. I think countries like Sri Lanka, for example, who has very quickly ramped up its surveillance system, has an existing, public health system since 1951, and has really effectively used its resources, including, providing essential health services that weren't related to COVID-19 to people's houses, to really tackle the pandemic head on. And also the state of Kerala, who's recently, I think it was yesterday, even recorded another surge of cases. But they know exactly where these cases come from. They know which clusters they come from. They have a long history in investing in their health system. And so they have these additional capacities to be able to respond to the pandemic. So I don't want to go on too long, but I think I'll just leave you with a couple of key takeaways, which is sort of in our preliminary research, we really see this combination of not only response capacity, because I think as we've seen, we've seen gaps in health systems that we perhaps thought we were better prepared, but we've also seen incredible resilience in countries where we perhaps weren't expecting that much resilience. So I think it's important to note that there is sort of a real political element to this pandemic, that the collaboration between political leaders and public health professionals is extremely important for an effective response, that a culture of health investments and properly investing in primary healthcare, not only in tertiary infrastructure, which includes hospitals, etc., but really also on the primary care levels, especially in low and middle income countries. And then finally, also to really think about the social contract, to think about what states need to provide to their citizens, and what it takes for people to trust their health systems and to trust the state in sort of tackling this pandemic, as has been really successful in South Korea, for example. So I think I'll leave you with that, and I look forward to the Q&A. Thanks.
Thank you very much for that, Nina. And thank you everyone for popping in so many questions. That will be great. Actually, I have one question for the three speakers to start off with. I was wondering if you could talk a bit about how, Marcel, you already touched upon how great it has been that the scientific community has been collaborating more, that there's been more partnership. I was wondering if Nina and Jeroen, you could also talk a bit about how you've been going from maybe scientific competition to collaboration, and if you feel as though that has been increasing.
Well, I'm for sure. I've been working with the local, with the health boards and clinicians straight away. So, those collaborations are extremely important. Also collaboration within, with the Welsh government, for example. And in effect, I think the willingness to collaborate has been absolutely great. And it's almost a different way of working. And in a way, I don't want to go back. I think, in terms of scientific speed, what Marcel was saying as well, it's been, it's been incredible. And you also then realize there's so much, how do I say this nicely? Crap, basically, all the time, that stops everything. So it's actually nice to cut through that and get stuff done.
Yeah. Sorry, I was just gonna come in. I think our position as a think tank is a little different, just because our focus is really on policy and sort of working with governments to, let's say, accelerate health reforms, focus on health security, etc. So I think in terms of think tanks, in terms of our role, is really to sort of bridge gaps between academia and policy, as well as sort of being a convening space for groups of people who perhaps wouldn't necessarily talk to each other in the first instance. So I think think tanks can really be a place for collaboration and for perhaps moving beyond the usual suspects in research. And, I'd like to see that continue and increase even more, and, increase ties with academia as well, to sort of accelerate impact of research on evidence-based sort of policymaking.
Thank you very much. Marcel, do you want to add anything to that, or do you feel so it's...
No, I think I already mentioned it in my introduction, that I think the collaborative spirit was actually very helpful in many ways, and I quickly saw that was also one of the questions that was asked by one of the participants. Everybody worked together, not only hospitals, but it was also between hospitals and community services with social services. And now this is something that we try already for years everywhere in the world, but certainly also in the UK. And now suddenly it happens overnight. So I think people really got a flavor, and it will have some long-term effects on how we organize healthcare, at least in the UK, I think.
Thank you. I'm going to jump to a question from Ewout, and this one is for Jeroen. Jeroen, what have you learned from this collaboration with its industrial partners?
It's a different way of working with industrial partners, for sure, compared to academic partners. So it's much more, I guess, it's result focused. It's much more applied. And of course, it's a little bit different because as you know, if you work together as an academic, you're not going to bother so much with NDAs and intellectual property and all these things. So that definitely it was part of the discussion. But of course, we need each other. So in the end, somebody needs to produce these tests and produce a device. In my case, but I've really enjoyed it, and I think. Yeah, I think it's, of course, good to have these links.
Thank you. Marcel, a question for you from Mark. He's asking, a huge amount of changes were implemented in hospitals in a very short period of time. He says, I expect hospitals are normally very bureaucratic and resistant to change. What positive changes do you expect to continue in the future?
Yeah, good question, and that's absolutely a matter of discussion now. So hospitals are bureaucratic, very hierarchic, not very easy to change. There is always a financial issue. Again, if you want to make a change, even if you have a good idea, there is an avalanche of PowerPoints that first need to be produced before you can even start talking about all that stuff. And suddenly it all happened. So I think people have learned that if you leave it to professionals, scientists, doctors, nurses, then change go much faster. And if you try to get decision making very low in the organization, so teams can take their own decisions and know what's best for them, and just give some conditions to say so you have to take into account this, and this. Then they're perfectly capable of finding good solutions. So that was for me, again, a learning point, but I think also for many of my colleagues, and now we try to keep it that way. Although it's difficult because it sounds a bit negative, but you know, there was a lot of bureaucrats which were hibernating during the crisis, and which was actually quite convenient because they didn't get in our way. But now they're creeping out of their holes and want to have meetings and more minutes of the last meeting and all that you know, bureaucratic stuff that's not really helping us. So yeah, we're finding a new balance now.
And how are you dealing with that, with people suddenly want to have an opinion on things while you have been on the front line all this time?
Well, try to be understanding. These people try to do their job, but try to explain to them that it actually went very well when they were not along. So in a kind way, you can try to explain it to them. And some of them actually now take another role, which is much more supportive and helpful.
Then I actually have another question for you right away, which is, how did you manage to keep your non-COVID hospitals COVID-free?
Yeah, well, that was right from the beginning that we had to find out because nobody knew. So we took a lot of interventions in terms of course, PPE measures. We had testing available, which really helped. So nobody could get in with a positive test, but also if somebody would develop a positive test, we would know immediately. Although it fortunately did not happen. So there was a whole set of interventions. We did scanning before we did operations. We did screening of family members if they accompanied their child, for example, to the hospital. And it turned out pretty well. So we have just evaluated it. We did during the peak time about 4,000 operations, for example, in cancer patients in one of these separate hospitals. And there were not a single seroconversion of COVID over there. And we're very proud of that. And in the heart hospital, it was exactly the same. So yeah, you can do it. And that's really helpful now. Now we actually have to separate COVID-free sites with possible COVID-infected sites. And we are still learning every week.
Thanks a lot. Actually, I have a question for Jeroen. It's from Ronald. He says, thank you for the interesting talk. Will the device be fundamentally limited to detecting one disease only? How about different varieties of the coronavirus?
So the interesting, one of the interesting characteristics of the technology is that you can actually use it for other diseases, for other applications. So if for example, if the virus would mutate, we can change the detection, but we could also use it for the detection of flu virus or norovirus or anything with DNA, basically. So I think also the pandemic showed that the molecular diagnostics will enter into a new era. So rather than only use it in the lab, hopefully it will be used more in point of care, because at the moment point of care is almost only lateral flow, so like a pregnancy test kind of technology. So I'm hoping that the molecular diagnostic tests, the different ways of doing this will go into primary care a bit more.
And because, I mean, you have been working on this test for urinary tract infections for 5 years, and all of a sudden it was kickstarted into the COVID-19 test. Like how did that, I mean, what happened those 5, like if you compare the 5 years compared to like 1 month at the beginning here, did you just completely have to kickstart everything, or were the previous 5 years so important in getting everything together that you could literally kickstart this right away?
Yeah, so those 5 years were very important because, for example, we already produced a prototype machine that was an ugly box with wires sticking out, but we knew it was going to work, and it costed only £100 to produce it. So we knew we could do this in an affordable way. And of course, we were learning using this technology ourselves as well. And the other thing is, and this is what Marcel was saying as well, is that there's much more collaboration between scientists. So actually the underlying molecular technology and how we detect it has been published, and we're just simply using that. So it means that we don't have to spend a year actually developing that. So it's a different process, I suppose. I've been much more like an engineer in the last couple of months rather than a scientist, just looking at all the different solutions that are available and put it together and simply make it work.
Thank you. One for Nina from Mark. He's asking, so he says you highlighted some examples such as Sri Lanka. What do you think are specific lessons that could be brought to the UK?
Well, I mean, the pandemic is different in each country, right? So it's tricky, but I will say that, countries that we've seen do really, really well are countries that, tried to sort of prepare as best as they could, and sort of initiated early decisive action. So, for example, in South Korea, you know, extensive testing and tracing. A similar story in Sri Lanka in terms of really mobilizing the surveillance capacity that the country has, however limited, and keeping the testing and tracing strategy rather than going into a mitigation strategy too quickly. By which I mean sort of starting to sort of lower testing too quickly. So I think those are sort of key lessons, as well as just really strong community engagement strategies. So as I was talking about before, trust of the population is really important, because when there's a breakdown of a social contract in terms of, you know, what people think that the state can provide them, what people think that their health system can provide them, adherence to lockdown policies, adherence to mask wearing is likely to be much lower, at least sort of from our evidence. So hope that answers your question.
Thanks. Jumping onto the trust bit, this is actually a question for the three speakers. How have you been comparing the Dutch response to the UK response?
Well, I can't really comment because I wasn't in the Netherlands during that. So
I can give a little bit of comment, because I followed quite closely what happened in the Netherlands, and of course what happened in the UK. It was remarkably similar. The Netherlands was 2 weeks earlier with the lockdown, and some people argue that the UK was a little bit late with the lockdown. That's a matter of debate, because lockdown also has disadvantages, as we all know now. But the numbers were remarkably similar. You know, and the very interesting difference is how much emphasis is placed on some things. So, for example, in the UK, the newspapers still are full of what terrible things happened in the nursing homes, and how well the hospitals did, but how poorly the nursing homes did. If you compare that with the figures in the Netherlands, it's exactly the same. So there are so many nursing home patients died in the Netherlands, or were not sent to hospitals, or did not get appropriate care, but nobody pays any attention. In the UK, everybody's talking about, you know, BME people from Black and Asian minorities have a much worse outcome. It's exactly the same in the Netherlands, but it's not even registered. It's not a debate. Nobody cares. So many things are the same, but the way people respond to it can be very different.
I think, Nina, this is actually something that you, the registration of data in Black and Asian ethnic minority groups is something that you have been looking at as well, and you mentioned in the video. Would you mind talking a bit about why data might have to be recorded differently, and what lessons what we've learned from the pandemic?
Of course. So I'm next to sort of my work at Chatham House. I also work as a volunteer researcher for Global Health 50/50, which is a research collective that specifically focuses on gender and health. And so we are currently running according to my knowledge, the only one of its kind, a sex disaggregated tracker on COVID-19, and we're trying to expand it to pretty much all countries in the world. So sort of preliminary, obviously there are the usual caveats with data quality. We're looking at data specifically from reported by ministries of health that is sex disaggregated. But in terms of preliminary results, we can see that, you know, generally women tend to get diagnosed slightly more, but there's a consistently higher death rate in terms of for men, and especially obviously there's the age factor as well. So of men that are older. So of course we can talk about possible explanations. We can talk about testing policies, you know, the overrepresentation of women in the healthcare workforce, as well as sort of that men tend to have a higher sort of chance of engaging in risky behaviors like smoking and drinking that potentially could play into that as well. But I think the fact that we're the only one of its kind of shows that, you know, you don't know what you don't measure, and we need to know more about how sex, age, and gender play into this pandemic. At a minimum, I think countries should be trying to report at least cases, death rates, and testing according to disaggregated by age and sex, because of course we don't know now what specific role they play. But as you know, this pandemic evolves, I think this information is really important for us to look at risk exposure and then risk of death connected to that. And also in the UK, you know, the fact that ethnicity is not necessarily, not generally recorded on death certificates is a real sort of challenge. If you're going to do it, you know, if, you know, as we all know, there was an inquiry, majority of doctors from that died were from BAME backgrounds. So, you know, it's really important that we not only, you know, measure what we don't know, but also that we value what we measure and we act accordingly.
Thank you. Nina, actually another question for you from Robert. Looking at other countries, do you think a track and trace app can really help prevent a second wave? And this is actually something that I would like to ask the other two panelists as well, but starting with you, Nina.
It's a tricky one. I'm not an epidemiologist. I think track and tracing apps can be very useful, but again, it's difficult when something like that would be mandatory, right? Again, in terms of like trust the population, I do think that, you know, they have been relatively successful in Sri Lanka. Sri Lanka developed a COVID-19 Shield app that was then also adopted in the Maldives. That was, you know, did really work. South Korea as well. They used a myriad of sort of database strategies to help with the response. But I think, will it prevent a second wave? This really depends on how many people download it and how many people use it effectively, right? And if that participation is voluntary, then it's yeah. I think it would be very difficult. I wouldn't know, to be honest.
Marcel, what do you think about the track and trace system?
Yeah, we do not exactly know how it would work out in the Western world, because actually the UK, again, thinks that we are the only country where it fails, but it's not available in any Western European or North American country so far. I think, like many things in public health, there is no golden bullet. So don't believe people who say, oh, if we do this, then that will happen. It's probably a combination of things. Track and trace can help, but it's also good testing, widely available, rapid testing, and it's also public health and politicians taking very rapid decisions and not waiting too long until taking the more difficult stuff. And then we will see what happens. And if we combine all that, then I think the disease will be manageable until we find the definitive solution.
Talking about collaborating with the NHS, this is actually a question for Jeroen. Are you considering having testing, I don't quite understand the question, having tested in the diagnostic development facility in the NHS? So I believe, yeah, would you want to partner with the NHS?
That's quite a technical question, I suppose. So our team, we're working together with clinicians with the NHS actually. So for example, our first batch of trials have been done on actually NHS staff. So we closely work together with the NHS, and yeah, so that's happening basically.
I'm just going to follow up with a question for you right away from Ewout. The diagnostic kit also has reagents inside. Do they need refrigeration, and how do you ship the reagents with the machine to countries far away from the UK?
Yeah, that's a good question, and of course it's relevant. And the honest answer is that I'm not entirely sure yet, because we have been working on like perfect conditions. But I know that, for example, if I keep the reactions on room temperature for over a week, it's still fine. But this is what I'm going to work on in the next month, basically. So of course, this whole pipeline of shipping and how it depends where it's going to be used, right? So in the UK, it's not so much of a problem that you have to store the samples or the test kits. I mean, in the fridge or freezer. But in low-income countries, it will be, of course. But every choice that we make in terms of reagents, we're trying to make it available at room temperature, basically.
Following up on that question right away, who are you targeting to sell the test to?
Well, I think what is going to happen, what is going to be more and more important is surveillance testing. So rather than purely a clinical test, what we've seen up to now is that people after having symptoms go for a test and then will be a positive or negative. I think to keep the infection under control, the pandemic under control, we need to do much more rapid and much broader testing across the country. I've had a lot of interest from many different sectors, basically. So dentists in London, film production companies, leisure centre people, basically, and anywhere where you would like quite a fast test. If it can tell you the result in 20 to 30 minutes, of course, it means that you can take a decision quite quickly.
Yeah, thank you. To Marcel, actually, there is a question from Norman. He asked, the general opinion of the public tends to be that the response in the UK to COVID-19 was too late. What would you say are the crucial processes that need to be improved for potential future pandemics?
Yeah, it's even now it's difficult to answer whether the UK was too late or too early. Many people believe that the UK was relatively late. Probably we will know the answer very far from now when we look back upon this episode. But I think what we've learned is that we need to respond a little bit quicker upon things that we see happening somewhere else. The advantage of the UK being late and being, going into lockdown 2 weeks after the Netherlands, Belgium, Germany, France, but also coming out of lockdown later than the others, is that we can actually see what happens in the other countries and learn from them. And if we see that there is a very broad rise in infectious cases in those countries again, I think the next time the UK will also quicker decide to go into lockdown. But we also know, we need to realize, that's all right from a medical perspective, but there are many other sides of a lockdown: social isolation, economic effects, people with mental health problems, people actually not getting the care that they need to. So it is a balanced decision, and I think it's too easy to say, oh, the UK was too late. People in the UK are very easily talking themselves down, in contrast to the Netherlands, where we think we're at the center of the world and the best in everything. I'm not so sure we were too late. We were a little bit late.
Actually, following up on that question, from someone, should a second wave become a reality in January and February, as suggested by the AMS report, do you believe the hospitals will be better prepared in London? And can the NHS cope in spite of the government's, debate?
Yeah. 2 comments. One, what have we learned from all the models in the past few weeks and months? Well, what I've learned is that they're all wrong. I've seen so many models and so many projections about the number of patients, the number of intensive care. We needed a Nightingale hospital with 5,000 beds. Actually, there haven't been more than 42 patients in the Nightingale hospital in London, and it's not different for all the other Nightingale hospitals anywhere else in the country. All the predictions failed. So what we've learned is that epidemiologists and model makers cannot predict what's going to happen, which is a comfortable conclusion, I think. What we now see, these little clusters in Leicester or in other parts of Lancashire, some parts of London popping up, is totally predictable because that's how infectious diseases behave, but it's also totally manageable. I think any second wave, however big or small it's going to be, is going to be different and easier than the first one, because now we know what to expect, we know how to diagnose it, we know better how to treat it, we know how we can manage outbreaks with isolation and some protective measures. So I think, yeah, I cannot predict what's going to happen, but I feel a little bit more relaxed and reassured that we will be able to handle it.
Was there ever a point in the pandemic that you thought you weren't going to?
Oh, absolutely. In March, in the beginning, when, you know, we were seeing a steep increase, but no clue whether it was going to plateau, how bad it was going to be, ITUs rapidly filling up, opening 10, 20 beds every day, and still they were being filled, was really stressful, not only because of all the work, but also because it was quite unpredictable and quite uncertain whether we were going to cope. And the last thing you want, of course, is having queues of hospitals in front of queues of ambulances in front of the hospital, full of patients that cannot enter the hospital because it's full. Some hospitals were close to that, but overall, I think in London we have been able to cope with the upsurged capacity to deal with it. But that was absolutely not a done deal in the beginning.
Oh, thanks. Nina, actually going back to you, there's a question from Ewout. If we need to obtain sufficient global herd immunity to stop waves of COVID-19, should high-income countries take responsibility to set up adequate facilities in countries that have spent the last year's allowed amount of their GDP to healthcare?
A lot to unpack there. So I think, okay, so I think there's one element of collective health security, right? It is also in high-income countries' interest to control pandemics that are happening across the globe. And I think, you know, there's a moral element to it as well. But of course, the reasons why countries end up spending low amounts of money on health, again, are quite complicated, right? Like, for example, in Bangladesh, there's really, really low health expenditure, partly because they have really stringent public financial management rules. So it's really hard to get money from the central levels all the way down to the health facilities, and then for the health facilities also to retain that amount and not having to send it back to the central facilities to be checked and then be sent back, right? So it's complicated, it's difficult, which makes a Ministry of Finance, for example, say, okay, well, if you're not utilizing the budget you already have, you're not getting any more money. So, you know, apart from stringent public financial management rules, generally sort of prioritization, limited fiscal space or limited financial room for countries to invest in health as well, the reputation of health being somewhat of a black box in some countries plays a role as well. But to sort of say that, you know, there's an implied thing there in that question where because countries are spending less on health, we shouldn't be able, you know, we shouldn't give any support, etc. But I guess in that sense, it's also our, you know, it's our global responsibility to tackle this pandemic. And we just see that in terms of the massive economic and social impacts that it's going to have, especially in low and middle income countries, that they're, you know, that they simply will not be able to continue tackling this pandemic without international assistance.
Thank you. Yeah. I just want to go back to one of the poll questions we had earlier on, which is about, I'm positive that there will be a vaccine by the end of the year. Jeroen and there we go, indeed. Quite a few of you were not too sure about that. Marcel, you mentioned that you wanted to talk a bit more about that.
Yeah, if I may start. This is a virus, it's non-mutating. And I don't know any example of a respiratory virus that's non-mutating, that's generating antibodies after infection, where a vaccine is not going to work. That's simple biology. And then people will say, yeah, but you know, the antibodies go away after a while. I was so surprised by that, because antibodies do not go away that fast. So I looked up that study from King's College. It's the most horrible study I've ever seen. If you look at the study, IgM antibodies disappear, IgG antibodies stay as they are, like in any other infection. So there is nothing new there. And actually IgG antibodies are persistent. And as many other people have pointed out, it's not only about antibodies, it's also about memory cells, immunological memory, T cells, and that's all there. So I can't see why a vaccine would not work in COVID-19. The Oxford vaccine generates a robust antibody response, has now been tested in 10,000 humans safely without an adverse event, and is in a clinical trial that will tell us whether this is actually a safe and effective vaccine, and we know the results pretty soon. And the Imperial vaccine will start next month with clinical trials, and looks also very, very good. And there's a couple of others that also look very good. So I don't know where this negative talk and all this pessimism comes from. Like almost every other comparable viral disease, vaccines will work.
Thanks a lot. Jeroen, your team testing, of course. How do you observe vaccinations?
Well, of course, I hope it's all going to work. That will be brilliant. I think, I mean, as a biologist, I agree with Marcel. And the other thing is that there are so many different teams and different approaches are being implemented worldwide. So, you know, there's just a very good chance that it's going to work. If it's going to be on time before Christmas, that's maybe another matter, because things need to be scaled up and be produced. It's basically, I think it's looking good, but of course we can't count on it completely. So we need to have the different strategies in place, and for example the testing. Some people do say this to me. Say, well, why are you doing this? Because you will get a vaccine anyway, so it's all going to be worthless. Like I said, I'm looking further than that, because we're producing a low cost and a rapid diagnostic device that could be used for many other diseases. And in a way, this is this pandemic has been a driver of innovation. And I think to have this kind of technology and what we've been learning about the molecular diagnostics anyway, is going to be very, very useful in the future.
Thank you very much. There are still some unanswered questions, but I'm afraid that we're approaching the end of the webinar. I just want to thank all the speakers for your great answers, your time, and of course all the work that you've been doing on this pandemic. Here are the contact details. Follow them on Twitter. In case you have any more questions, by all means go there. Then if you have any specific questions for the Dutch Academic Network in the UK, you can also contact them. I want to say thank you to the Dutch Academic Network in the UK, and of course the Dutch Embassy in London for organizing the event. In case you do want to watch this webinar again, it has been recorded and will be shown on YouTube and Facebook, if I'm correct as well. I thank you everyone for joining. It's been a really good afternoon, and I hope you leave this webinar feeling inspired and intrigued, and hopefully a bit more positive and safe. And we all hope to see you face to face at an event in the future. And for now, have a great weekend, and see you soon. Thank you.